outcome of that decision and that counseling conversation become a reality. So we help health systems integrate a pregnancy intention screening question into their EMR. You're probably familiar with the concept of one key question and the idea that if you ask women, do you want to become pregnant in the next year, that really helps them to engage in a conversation about their goals and their options, as opposed to other counseling structures like, are you using birth control, which can sometimes be perceived as intimidating or judgmental to some patients. So the technical interventions that we help with are integrating that question into the EMR so that the staff is prompted in the counseling conversation, and then working with clinics around issues of workflow, scheduling, room setup, tray setup, so that they're really prepared from the beginning of the day to the end of the day, that if a woman is there and she would like access to any form of birth control, that they can follow through on that request and are able to provide her even the more complex forms of birth control, like the IUD or the implant, in a single day, so that she doesn't need to make another appointment, potentially multiple other appointments, which we all know the likelihood of her getting back there isn't always that great when she's already there to begin with. So the final piece that we offer health systems help with is consumer marketing and patient education. So at the clinic level, providing patient-centered, non-intimidating, non-medical sounding, instructional information, marketing materials in the waiting room to help tee up the counseling conversation that's about to happen with the provider. We also run a consumer marketing campaign to help bring more women through the doors of clinics that we've worked with who are prepared to help them access free birth control and are able to do that hopefully on the same day that they're there for their visit. So our model was really inspired by the CHOICE project, which was a study in St. Louis that began about 10 years ago and asked the question, if we're able to remove all the barriers to women that they face in terms of accessing all forms of contraception in one visit, what will the outcome of that be? The outcome was that women overwhelmingly chose the most effective forms of contraception, or LARC, and that led to dramatic decreases in teen pregnancy and also in abortion rates in the city of St. Louis. Some of you might also be familiar with the Colorado Family Planning Initiative or the Iowa Family Planning Initiative. So our work is really grounded in a lot of that clinical evidence around what are the best practices to help women get access to contraception. And I would say, actually, most importantly, women who participated in the CHOICE project had much higher rates of patient satisfaction with their visit and with the care that they received because they were engaged in a more in-depth conversation about their needs. So since the CHOICE project, Upstream has been up and running. We've piloted our model in 5 clinics in 5 states, and we're just in the process now of wrapping up our first statewide initiative in the state of Delaware. You might wonder why we chose Delaware. Well, Delaware is quite small, and so if you want to do a project where you're trying to reach every woman of reproductive age who doesn't want to get pregnant, Delaware is where you go. Delaware also had the highest rate of unintended pregnancy in the United States when Upstream began our work. 57% of pregnancies were unintended in the state of Delaware. And Delaware had incredibly engaged political leadership to really galvanize the healthcare system across the state to say, we're going to work together and provide better choices and better options for women in Delaware. So Upstream has been working in Delaware for 2 years. We've seen the rate of LARC usage in Delaware double. And we project that based on that rate doubling over the last 2 years, that we would see a 15% decrease in the unintended pregnancy rate across the state. Now that's just based on the work of the last 2 years. Obviously the sustainable changes that we've made in access will continue to have benefits for women who are new to going to the doctor every year, but those are the results that we've seen so far. So some of the work that we've done in Delaware, we've trained over 2,000 staff and clinicians at 90% of health centers in the state. And we've reached the equivalent of the number of women of reproductive age in the state of Delaware who need access to publicly funded contraception in order to achieve those rates of LARC uptake and likely unintended pregnancy decrease. So just for a little bit more background on what our model looks like at a clinical level, I have a case video to show you of an FQHC that we worked with in Worcester, Massachusetts. So what I really like about that video is it kind of shows the integration of the clinical training, the care team collaboration, and all of the administrative work that has to go on behind the scenes to make this easy and seamless for women. I was talking to an OB provider at an FQHC that's based in Seattle a few weeks ago, and she said, you know, I think we do a lot of the components of this, right? Like our staff are trained on doing placement of Nexplanon and IUDs, and we have mostly Medicaid patients who are covered, so they have access to it, but all of these systems aren't working together. So whenever I have a patient who wants Nexplanon or wants the IUD on the same day that they're there for a visit, I, the OB, the most expensive person in the building, am running around and kind of process re-engineering from the back end. How are we going to help this woman get access to the most effective method today? She's like, I'm going to the billing person and I'm saying, can you call her insurance provider and see what's covered? And then I'm running over to the clinic manager and I'm saying, I need a room to do IUD placement. And so if we're able to just work a little bit further upstream and plan for those kind of contingencies, women are able to get access to all methods, and they're able to do it in a way that doesn't disrupt the entire flow and the entire day of that provider or of the other people on the care team who are involved. So in Washington State, we are just kicking off our work and our partnership with the State Department of Health and Healthcare Authority this year. We have grant funding to provide quality improvement services to safety net providers across the state for 5 years. Our hope is that we can work with all the FQHCs and as many of the kind of safety net or critical access hospital systems as possible in those 5 years. Our goal is to reach all the women of reproductive age in the state who we estimate need access to publicly funded contraception. So our timeline for this work is this year is really a year of kind of planning and building and scaling. So we're working with the 9 ACH organizations across the state to figure out how do we integrate our quality improvement offerings with the practice transformation projects that are happening among the 9 ACHs across the state. We're hiring a staff so that we can have quality improvement staff based all over the state of Washington, including in Spokane. And we're also working to develop partnerships with the first 10 sites or organizations that we'll work with to provide quality improvement services next year. Our goal then is to work with at least 40 agencies across the state and to stagger those in a cohort model so that we're working with roughly 10 or maybe 12 sites per year. So in terms of the types of agencies we hope to partner with, I think first and foremost is organizations that serve the population that's most in need of publicly funded contraception, FQHCs, safety net providers, organizations that will help us reach those women. I think a really critical component of success is engaged leadership. So this is something that impacts, you know, an entire organization. It's not just the clinical team. So clinicians, administrators, even IT people will be involved. So having leadership buy-in from the entire leadership team and individual site leadership is really critical for success, is something that we found in our work in Delaware. And then finally, like any good quality improvement program, we need to be data-driven and set specific and measurable goals for our work and be able to work with organizations that value data and measurement, who are interested in setting goals, benchmarking their program and their progress, and being able to say at the end of the 6 to 12 months that we work together, like, yes, we did it. 99% of women are being asked about their pregnancy intention. 99 or 100% of women are satisfied and feel like they made the choice for their birth control today, and a couple of other really critical factors we like to measure. We also know that there's a lot of work that's already been done in Washington State around contraception access and reproductive health. So forming an advisory committee to make sure that we're informed by all of the work that's already happening, and also to just get advice from leaders in healthcare, community leaders across the state about, you know, do we have the right strategy for sites we're trying to work with? Or how do we do the best possible job of operating with cultural humility and working with different communities across Washington and making sure that our training is appropriate based on where we're doing the work? So we're very excited. First Lady Trudy Inslee is chairing our advisory committee, so we're very excited about that, and we're working on recruiting leaders from across the state to be part of that. So thinking about how leadership teams and people who are engaged with the accountable communities of health can help and how we can work together, I think first and foremost, just continuing to have the conversation about why it's important from a public health perspective that there's no wrong door for contraception access and that family planning should be integrated with primary care is really important. Encouraging health systems to then take the step of working on that integration in the same way that we've done so much good work around behavioral health integration, bringing family planning and contraception access into that same fold. And then finally, making recommendations about health systems who would be a good fit to work with Upstream, who care about this type of work, who are ready to do some quality improvement around contraception access, and who have that leadership engagement that we know will help make their organization really successful at implementing this program. So that is the overview of Upstream. I'm happy to answer any questions that you have in the room or that we have on the webinar.
So what is the commitment from the FQHCs that you work with? So one-day trainings, what can they expect?
So the commitment that we expect from them is to partner with us for a finite specific time period. It's usually 6 to 12 months depending on where they're at when we start and what the goals look like in terms of the end product. We want to see them integrate pregnancy intention screening into their EMR and be asking that question of every woman of reproductive age, does she want to become pregnant in the next year? They need to be able to share data with us around the quality improvement metrics, and then be able to get the entire staff to go through training. So that can actually be one of the biggest challenges, is just from a scheduling perspective. So the way that we've sequenced the work is starting with data collection, and that takes a couple months to get up and running, then doing the quality improvement planning, which takes a couple months, and then doing the training, so that it's possible to actually, because we know it's going to take 4 months to schedule a training. It's just going to take forever. So trying to front load as much work. And then the other reason we do that is because we really want staff to leave the training and be able to use what they learned immediately, if not almost immediately. So we need time to work with them around adding the pregnancy intention question into the EMR before the training, because the worst thing would be they go to training, they're really excited about this, and then they don't get to practice their new counseling skills for weeks or a month or whatever. Great.
Do you have experience with, we're a nonprofit that serves homeless women and young teens, and do you have any integration with health systems that come in and do on-site into some social service agencies?
Yeah. In Delaware, we had a whole team that worked on non-clinical sites or community partners, and understanding that community partners have a really important role to play in starting the counseling conversation and being able to make referrals to sites that will be able to follow up and provide that service to the women they're working with as soon as possible or on the same day. And then also some community partners that are providing, some medical services, but they aren't a clinic, right? So some like needle exchange sites where maybe they're doing wound care, those people can do Nexplanon. Maybe they can't do an IUD, but they can do the implant. So we did a lot of work in Delaware to kind of figure out what's the different counseling model look like in a non-clinical or a community setting. And part of our work in Washington State is then kind of figuring out which community partners can we work with to help either, bring clinicians to those sites, or when we talk about patient education and patient outreach, working with those sites to help bring more women to the doctor. And one byproduct that we found in our public marketing in Delaware was providing a message to women around free birth control was really the most effective message in terms of getting them through the doors. We tested a lot around, does educating them about effectiveness of methods compel women to go to the doctor. It doesn't. It's too much information to try to convey in a Facebook ad, right? But do you want free birth control is a really interesting topic to a lot of people. And so I think that helped us reach a lot of underserved women and get them in the doors, to go to the doctor. And then if they're going to a Planned Parenthood or if they're going to an FQHC, they're probably going to get other care than they wouldn't have otherwise. One funny story from Delaware. So we did this whole consumer marketing campaign. It was called Be Your Own Baby. And it was really targeted at kind of younger millennial women, right? The 17 to 20-year-old age bracket that's at really high risk for unintended pregnancy. And we had a few sites that they were very conservative and they did not like that approach. They were like, this is very sexy. This is too sexy. We're like, yes, that's what this is about. If you wonder if that's what we were talking about when we were talking about birth control, that's kind of the point. But it was helpful, to learn too that different organizations are going to have a different approach, and that sometimes you have to work within, that context to be successful. Similarly, working in like a pediatrics setting, there's a different approach and different message too. Great. Well, I appreciate the time. Would love to, follow up with conversations if you think this is something that would be interesting to either the provider organizations that you work with or community partners, or even thinking about how MCOs and Upstream can work together. MCOs can work together as a group as well. So we're just getting started in the state and hope to continue the conversation. Thank you.
Thank you so much, Chelsea. Our next speaker, I believe, just walked in.